Okay. So thank you everyone for being on the call. I hope you're having a good morning so far. So before we start with our first speaker, I wanted to go over a couple reminders. So to make sure that your name is in your Zoom profile so we can count your attendance. We welcome you to have your cameras on. It's always nice to see your faces. Please be respectful and attentive to our speakers and your fellow students. Keep yourself muted when you're not speaking. If you would like to speak, you can use the raise hand function and you'll be called on. And you can use the chat function to ask or answer questions, and we'll do our best to answer everything time permitting. So our first speaker is Sylvia Schiber. She is the Assistant Director of Radiology at Kaiser Permanente, South Sacramento. Sylvia has been working in radiology for 30 plus years. She started her career as an X-ray technologist and then to a mammographer, and is currently in management. So welcome, Sylvia.
Hello, everybody. Hi, I'm Sylvia. Let's see. Let me see if I can share my screen because I created a little presentation, and I'll be open for any questions. Sometimes I get to talking a little bit too much, but I'll try to stick to my slides here. So I'm going to share and okay. Can you all see my slides?
Yes.
Okay. Okay. All right. So I'm an X-ray technologist, and I'm just going to share with you how to become an X-ray technologist, and also I'm going to go over some other areas in imaging. So right now I'm one of the assistant directors at Kaiser Permanente in South Sacramento. So in the imaging department, we have several different areas, but I'm at a hospital, so it's a very busy place. But I'm going to go over this a little bit with you on how to become an X-ray technologist. Um, and as you heard, I've been an X-ray tech for over 30 years. When I got into the role, I was younger, right out of high school. Wasn't very popular job at that time, but there was a school close by. Thought I'd jump into it, and here we are 30 years later. I'm still doing it and love what I do. So what is an X-ray tech? Why is that not sharing? Sorry, hold on here. Okay. So what is an X-ray tech? An X-ray tech it's a technologist that performs X-rays on patients to assist with any type of diagnosis. So this is an X-ray here. It's using an X-ray machine. Now, an X-ray technologist is a person who takes the images, and a radiologist is the physician that reads the X-ray or other imaging exams. So I'm an X-ray technologist. So what I do is I can take X-rays like this, and then the radiologist will read them. This here is an arm, and it's a broken arm. But that's just an example of things you do. Not everything's broken. I can tell you, when I started my career, I thought this is all I would be doing is seeing patients with broken arms and taking these pictures. But as there's more to it as being an X-ray technologist. But to become an X-ray tech, there are two different pathways you can go. But what the minimum is needed is an associate's degree. It's the fastest way to become an X-ray tech. It's a 2-year associate program, and it's usually offered at a junior college or at a private certified education program. And right now, there are some colleges local that offer in the junior college, and we also have some private certified programs in the Sacramento area as well. There's the junior college that is probably the more economical way to go. There's the private programs. Those private programs can offer associate's degree or a bachelor's degree. Or there's also some universities and colleges that do offer a major in radiography, it's called, and you can get your bachelor's. When you go to school to be an X-ray tech, It's going to school, one of these two, the junior college and the private. You are doing it coincidentally of going to school and also learning hands-on and clinical. So half your day you are or half your week you are attending classes, the other half of the week you are doing hands-on clinical. So right now where I work, we do take students. We have first year students and second year students. Um, I feel like it's a good way to learn because you're not just in the classroom, as you're learning in the classroom, you're coming to your clinical site and performing what you learn. So it seems like a lot when we get new students very at the beginning thinking, oh my gosh, how am I going to learn everything? But as you're combining the education and the clinical hands-on, it all kind of pieces together. And by the time you're done with your 2 years, you're very confident to work on your own and to get a job. Certification, there are two certifications in California you need if you go to another state. Um, some states require their own certifications, but in California, you need a state licensure and also an ARRT. It's the American Registry of Radiologic Technologists. All states require this certification. So upon completion of any of these programs, you are going to have to sit for some board exams. In California, it's great now where you only need to sit for the ART and California will accept this certification if you pass it. All you need to do is pay for your fees for California, and they'll give you a license. If you don't want to sit for this ART first, you can always take your state licensure first in California, and then as things settle, you can go back and take your ART certification. So there's two certificates. ART, it's an annual renewal, not so expensive. I think it's like maybe $60 a year. The state licensure in California, it is renewable every 2 years. And that's over, I would say it's between $150 and $200 every 2 years. But not all states require the licensure. But if you are planning to go to and work in California, I do highly suggest that make sure if you attend any of these colleges that they're accredited, so you can sit for your boards for these courses. There are some colleges out there, or not colleges, there are some education programs out there that offer X-ray programs. I always advise be sure that those programs offer the combined learning and hands-on clinical training. Usually schools will already have contracts with healthcare facilities to provide the clinical training. There are some schools that will tell you they provide clinical training, but they tell you that you need to find your own healthcare system to get the training. That's very difficult to do because there's a lot of liability, a lot of insurance to go behind it. So I always suggest to stick with a certified private education program if you're going to go that route and make sure they're accredited. Any questions? Okay. All right. X-ray career. So once you become an X-ray tech, you can get jobs in different areas. You can work in a hospital, you can work in a private clinic, you can work at a private imaging center. There are operating rooms, surgery departments. Those can be out in the hospital or outside the hospital that an X-ray tech will need to support. Emergency department, so hospitals, we always have technologists in all the hospitals that perform X-rays on any emergent exams, and that even includes trauma. So like right now, I work at a level 2 trauma facility, so all the X-ray techs here are familiar and our students are learning on hands of how to work with trauma. So a trauma is car accidents, gunshot wounds, anything that can be coming in that's a very emergent need. Usually after the physician and the nurse assess the patient, X-ray is always standing right next to that emergency room physician or surgeon, and we are taking x-rays as soon as that patient comes in. So for example, I'm in the hospital, we'll sit overhead, we hear trauma alert. We know that trauma is coming, so technologists go sit in the room waiting for that patient to come in through the ambulance. And we have a machine there that we take portable images. So, and we wait for that surgeon as their or ED physician directing the technologist what images to take as that patient comes through. There's private imaging clinics, there's orthopedic clinics, there's always x-ray support in these areas, urgent cares, um, and inpatient. So not all the x-rays are always just done in the emergency room in the hospital. They could be a patient who's been in the hospital for a while and they've been in a room for a week. And sometimes their physician will say, "Hey, I don't know what's going on with this patient, but they seem to be, getting sick and we need to take some x-rays." So they'll order some x-rays and the patients will come down to the x-ray department. X-ray techs work very closely with physicians and other healthcare professionals. And and the starting pay in California averaging around 65, 70,000 a year. And that's at full time. Um, Very possible to advance in that. I have technologists here that make more than that. They do work some overtime, but as other healthcare organizations, as you spend years into an organization, your salary increases every year, depending on the organization. Usually, not usually, I'm going to say this salary does not count for benefits. So most organizations, if you get a full-time position, will offer benefits. So when I'm saying benefits, I'm meaning healthcare benefits, where if you need to go to the doctor yourself, the company will provide that, and sometimes with the employee contributions. And also they have good pension plans or retirement funds where you put money in, and when you retire, you'll have a separate savings fund for that. So those are retirement funds. It's like a separate savings account other than your own bank account. Let's see. X-ray equipment, these are two different types of X-ray equipment that we use in the hospital or even outpatient, but I could say in the hospital. This is a standard X-ray table. This is the technologist here. Here's a patient. You're going to use this machine here to do any type of X-ray. Sometimes the patient can be sitting down if you're needed to X-ray an arm. This here is another receptive receiving area. If you need to do any upright x-ray, so saying like a chest x-ray or a shoulder, you're going to use this area here. This is a different receiving area. So this, what they call it, a tube, can tilt and the patient will stand up and use this x-ray board here, or the x-ray patient can lie down and the receiving area is down here, and the x-ray beam comes here. This here is called a C-arm, and it's on wheels. This is a type of equipment we use in surgery, or sometimes private clinics, like a pain clinic, any type uh, of procedure where we need a supportive physician with real-time imaging. So a little bit different here. These images um, are one-time imaging. This here is like a movie camera. So there's a screen here. So as you're imaging the patient, it's like real time. So for example, if the physician's inserting something into the patient's body, this type of equipment here will allow that surgeon to see real time to be able to do whatever procedure they need to do. Like say for hip replacements, they can use this to make sure that the hardware they're putting inside the hip is in the right area. This piece of equipment here, this is the last one here on the right, is a portable x-ray unit. This unit we also use, this is one we use most of the time in the emergency department for our trauma cases here. there's a plate of film that you put behind the patient. This is the X-ray tube here, and this goes up and down as adjustable. And this is what we use to X-ray any of our emergency department trauma patients. This can also be used in the operating room, and this can also be used on the patient floors. This is mostly used in the hospitals. We use it on the patient floors if the patient is unable to come down to the X-ray department. We use this piece of X-ray equipment to image the patient in their bed in their patient room. After you become an X-ray tech, there's always room for advancement. There's CT, which is computed tomography. That's a different type of X-ray imaging that is used very frequently. A lot of diagnosis, it's cross-sectional anatomy, but we have some technologists that move on to become trained in computed tomography. We also have X-ray techs that get trained in doing MRI, magnetic resonance imaging, that is not using any X-ray field. It's using a very powerful magnetic field and utilizing radio waves and a computer to produce images. And I'll show you some images of that. There's a mammography. That's my background when I moved on. So mammography is taking images of the breast to evaluate for breast cancer, can be male or female. We take imaging. There's also interventional radiology. So this is also using radiation equipment and assisting radiologists or surgeons in performing high-level procedures, invasive procedures. So like angiography, where say a patient is, you need to look into the arteries, things like that. We use the angiography. If the patient needs a biopsy of the liver, the technologist is using the imaging equipment to support the radiologist on where to go for the liver. Can see the liver. The radiologist will be able to see their needle go into the liver to make sure they're biopsying the liver, and the same with the lung. So it's 100% being with the radiologist or surgeon on these type of exams. This is a CT equipment. This is what images look like for a CT. These here are the kidneys. This is part of the pelvis. You don't see the lungs so much here. Here's the lungs here. So these little white things are the ribs. This is your spine. So it's a cross-sectional. So it's doing, if you think about it, it's like a slice of bread. So if you have bread slices, the computed tomography, instead of taking an image of the whole body like an X-ray exam does, you look at it like a slice of bread where you have the whole body, but it's little slices so you can see more detail of the body. This is what a CT machine looks like. Patient lies here. The patient goes through this little hole. Here's a scanner, and this machine, it gets hot, but it's all inside. So how this happens, the X-ray machine is inside this capsule here, and it spins really fast as the patient goes through, and it creates all these little slices to create this type of image. Looks similar to an MRI scanner, but it's not as deep, and the X-ray is in this little donut here. And what happens is this table moves and the patient slowly goes into the machine. This is an MRI scanner. Images look a little bit different. The machine here is a lot bigger. This is a giant magnet in here. So if you look at the two, this is a thinner, this is thicker, but this is a giant magnet. This is a very powerful magnet. If you see this room here, it's pretty much clean of anything, because any type of metal that can go in there, it can get pulled into this magnet. It's a huge safety concern, and the technologist has to work in a very safe environment, and be aware. So for example, if a patient or anybody, say the door's over here, if anybody got anything metal close to the door, this giant magnet can pull that piece of equipment right into this little donut here, and you won't be able to get it out. It's a very powerful force. For example, there have been times where someone has brought in an oxygen tank and it'll get sucked right in here and you won't be able to take it out. The force is very strong. If you walk in with a paper clip, it's going to suck the paper clip and it'll get stuck inside of there. You know, when you go in for this type of exam, we have patients take everything off. The technologist has to be sure that the patient has no jewelry, no metal in the eye, no boots. Like sometimes people wear boots with metal tips. Those will get pulled up into the scanner. So it's a fun position, but very, very a lot of safety that you need to follow with this exam, being a technologist in MRI. This is a mammography machine. This is what I do. This does some breast exams. This here is an example of what an interventional radiology room looks like. It can be busy. There's nurses, there's technologists, and there's surgeons, but this is just the type, it's a high level C-arm like that other machine that I showed you, but this is permanent, that stays in the room. It's a high level machine that the surgeons use, and they have a very fancy screen here to see the detail of the procedures they're doing. Other careers in imaging that don't involve radiation, we have ultrasound. This is an ultrasound tech here. It's using a handheld probe, scanning over the equipment. You see your image here. Of course, we always see babies with the ultrasound unit, and that's a very common study that is done, but you can also do other procedures like looking at the liver, appendix. You can determine if there's appendicitis, pelvic exams, looking inside the bladder, ovaries, things like that. It's a highly skilled profession, but this is another imaging career that's in the imaging department. We also have a nuclear medicine tech. So nuclear medicine tech, those aren't as, we have them in the hospitals there, and there are some in outpatient. Not much, it's not a very big department. It's a very small department. It's very detailed department. So the nuclear medicine technologists, they are highly skilled. How those images are produced is this technologist will start an IV in the patient's vein. They inject a radioactive solution or a liquid into the patient, and the patient will rest for about 45 minutes. And it's a radioactive tracer, they call it. And you need to let that radioactive tracer get absorbed by the tissue. And then after it is absorbed, imaging is done. And this patient doesn't go in and out. You're just lying here. And this is all about sensitivity. There's no X-ray coming from this machine. All the radioactive material is coming from the patient. And this is images of what PET can look like when it is absorbed into the patient's body. Radiologists read these as well. All these modalities I'm sharing you, a radiologist reads those, not a technologist. These are just technologists performing the studies for the radiologist to read. Why I chose to become a technologist, I can be honest, I really didn't know what I was getting into. But after I started doing it, I loved it. Every day is different and can be challenging, especially in the hospital. You don't know what you're walking into. Some days can be busy, some days cannot be so busy. You can have a lot of trauma cases. You could have a lot of walk-in x-rays, broken arms, patients coughing. Flu season's very busy. You do a lot of chest x-rays. And it's rewarding. You're always helping people. You're working in a healthcare environment and being part of the healthcare team, because even though you're with radiology is a big team. So you have the radiology team, but you also have your healthcare team too in the department. The technologists are always working with either transporters, nurses, respiratory therapists. There's so many different areas inside the hospital technologists can work with. If it's outpatient, you're still working with a radiologist, you're working with schedulers. There's quite a bit of a team that goes with it. Not really an independent position that you would do. You're always working as part of the team. Yeah, there are times when you can work at a clinic, you're the only technologist there, say like at an urgent care, but you're still going to be part of the urgent care team and that urgent care physician. Let's see, I kind of went pretty fast there. Um, that's all I have. Any questions for me?
There was one question that was put in the chat. How do you
Oh,
think
I'm sorry.
No, that's fine. How do you think AI will affect your job in a few years?
Oh, so AI, as we're going right now, AI is pretty much not, because healthcare is so busy, AI at this time, there's no machine equipment that will take over where a patient, or I'm sorry, a technologist will take over a technologist's duties. All the AI right now that's coming out for imaging and even future is supporting the radiologist to be able to help read their studies. There are AI that, maybe highlight an area of concern or dictating the reports because the patient volume keeps increasing. The radiologist can't keep up. And technologists with AI right now, technologists are not impacted by any AI. The only, maybe our equipment may advance, and it's just learning the new equipment. But so far, no future of AI replacing a technologist at this time.
What does your work schedule look like?
A work schedule. So in the hospital, there are different schedules. We have part-time staff, we have full-time staff. We are 24/7. So an X-ray technologist, there's different shifts. There's an AM shift, there's a PM shift, and then there's a graveyard shift. We call them the night shift. So depending on the employee's needs, there's different shifts they can work. The night shift, it may sound terrible, but the night shift, they love their shift because they get to spend their daytime with their kids. The day shift, maybe they're just their usual. They like to be on a regular schedule. It's 7 days a week. Some staff work weekends, some staff don't work weekends. But if you want to be more on a regular schedule, there are outpatient clinics or urgent cares where you're more on a daytime routine schedule. Some facilities, technologists take call. Where I'm at, we don't take any call. We are always staffed 24/7.
Okay, another question. We have time for one more. I would like to become a radiology tech, but I'm not so good at math and physics. What advice would you recommend?
So, what I recommend if you're in high school, I would start. I can say it's not always easy for everybody. And I'll be honest, I was very challenged with physics. But it's a different types of physics. Sometimes I would always recommend if you're taking it now, if there's an opportunity to take it now, try to take it now in high school so you get a head start because you're going to need to take it again in any type of health or any type of x-ray program you're going to. So just to get a head start. But I could tell you when you get into these specialized programs, the teachers understand that some of the students will have weaknesses and strengths in different areas, and they're always helpful. Every x-ray program that I've worked with, I've had students that struggle with physics. Either they get extra help or work with a peer, one of their classmates, to help them understand, or they work extra time with their teacher just so they could get through it.
All right. I'll give one follow-up. Joanna is our next speaker, if she doesn't mind one more question. How much is your health affected from the exposure of the radiation?
So I've been doing it for a long time. We wear dosimetry badges. Every technologist, anybody who wears with X-ray wears, it's called a dosimetry badge. And so it measures how much X-ray you're being exposed. So we have technologists that have been here for 20 something years. No issues. They wear their badge. We have a head radiologist that reads these, monitors these reports every month to make sure somebody doesn't get to a high level of radiation dosage. But everything's pretty safe. We wear lead aprons if you're going to be in direct contact with radiation. We have thyroid shields. There are lead glasses everybody can wear. So a technologist can be as safe as they want to be, because we provide all the safety equipment for that technologist. We do require for employees always to wear a thyroid shield and the body shield. The lead glasses are always up to the technologist if they want to wear the glasses. I
Okay.
wear glasses, but that's just because of the computers that I look at every day.
Well, everyone, please thank Sylvia. We really appreciate you being on the call and sharing this with us.
Okay, great. Thank you for your time. Let me know if
All
you have
right.
any questions.
All right. Thank you. Okay, we're going to jump to our next speaker. Joanna Roberto, she's the program manager for the Sacramento County Opioid Coalition. She's going to talk a little bit about harm reduction. She also works with me at SSVMS. So welcome, Joanna.
Hello, thank you all. I'm going to do a two-part presentation. One part will be doing some Narcan training, and one part will be talking a little bit more about careers and harm reduction. So let me go ahead and share my screen. All right. Pam, are we all good? You can see it?
Yes.
Perfect. Okay. So quick question for everybody first. We're going to be talking about opioids, overdose, naloxone, or Narcan. If anyone could put like an emoji or in the chat or raise their hand, how many of us have heard of Narcan or have received a Narcan training before, like at school maybe? Anybody? Last session, a few kids had, so I was curious to see if anyone else had. No one so far. Okay, well, that's great. We'll do some new stuff today then. So first, I'm going to introduce a little bit more about the coalition. We're going to talk about what we do and why we do it, and then we'll talk about opioids and naloxone. So the coalition is part of SSVMS. We work with the county, we work with law enforcement, we work with community members, with nonprofits, and our main goal is to save lives. And so we talk a lot about opioids, misuse, overdose, and reducing stigma. So we do a lot of different programs. We do trainings just like this one for schools. We do it for like professional organizations, for people who work with people who experience homelessness. And we work with doctors to provide training on harm reduction and medication-assisted treatment. We meet every couple months. We host an annual fentanyl summit, and we do a couple other programs. One of our main goals right now is Narcan training and distribution. So let's get a little bit more into like some background about opioids and fentanyl so we understand why we talk about Narcan so much. So why do we talk about opioids, right? Why is this something we talk to you guys about? Why is this something we go to schools about? So everybody you see here on the screen are people in Sacramento area who passed from either opioid overdose or fentanyl, right? These are people very young. Most of these people were younger than 25 or in their teens. These are people with stories and with families. And so opioids and fentanyl are taking people's lives every day. This is something that is affecting many people in our community. And so we want to talk to people your age, people older, people who work in the professional world. We want to make sure people are aware of what the issue is and then like what we can do about it, right? Because we can save people's lives. So let's get some background into what opioids are. Many of us have heard of them. We know they're like drugs or medications, but where do they come from? What do they do? So we get opioids, the drug, we get them from poppy plants. So we extract opium, we semi-synthesize it. And the way that opioids work is they attach to opioid receptors we have in our nervous system. So all of us have built-in opioid receptors. They're in our brains, they're in our nervous system, and endorphins are hormones. They attach to these brain receptors and we release them during like injury or stress or crying, and they make us feel really good or they help us reduce pain. And so what opioids do, the drug, is they create this huge sensation of like this huge rush of endorphins, have a lot of pleasure, and reduce a lot of pain. So opioids you guys might have heard of are like fentanyl, morphine, heroin, and then a lot of prescription pain relief, so like Norcos or Oxys or Percocets. So those are drugs you might have heard of before. And they work just like I said before by using our natural built-in systems. I like to give that background, and then I like to focus a little bit more on fentanyl. I'm sure many of you have heard about it, like in the news, maybe seen it. This is something we're really worried about, and I like for you guys to have a better understanding of why we talk about it so much. So fentanyl has been used in the medical field for a very long time. It's been used in a safe and legal and controlled way. We use it during like procedures and surgeries. Sometimes it's prescribed for pain relief, like as a patch. But this is a really strong drug. So it's actually 50 to 100 times stronger than heroin. And that's why we focus on it so much, because it's so strong that it's highly addictive, it's easy to make, but it's also very lethal. So there's a picture on the screen and it shows the tip of a pencil. So that's how much fentanyl it takes to cause an overdose. It's not very much. We talk about this because they're putting fentanyl in lots of things, right? They're putting in other drugs like meth or cocaine, but they're also pressing it into pills. And there's a lot of pills on the street that look like they're legitimate, right? That look like they come from a pharmacy, but actually have fentanyl in it. And it only takes one pill to cause an overdose. So I don't know if you guys have seen like the One Pill Can Kill campaign or How to Arrive Alive Come to Your School, maybe. I see some nods. Okay, great. This is why we talk about it, right? Was that a question? No, okay. Um, the reason why we talk about it, we go to your schools, is because this is such a big issue, right? We've seen a lot of overdoses and a lot of deaths from kids who just take one pill one time, right? So each of the pills on the screen one is like what we call a real pill. So it came from a pharmacy, right? This is like a Xanax or a Percocet or an oxycodone that was prescribed. And then another picture on the screen are pills that come from the street and have fentanyl in them. And the reason we show this to y'all is so you understand how similar they are and how you can't really tell the difference. So if you're at a party or you're at a festival, you're at a rave or wherever you are, and someone gives you a pill and says, oh, like this is an oxy or this is a molly or whatever it is, you don't know where that pill came from. And whoever gave it to you might not know either, right? They don't not trying to cause any harm, but it can have enough fentanyl in it to cause an overdose and to kill somebody. And so we want you guys to be aware that that's out there and that it's dangerous. And we also want you to know what to do about it. So we'll talk about Narcan and overdose. Before we get into the Narcan piece, talk about like what an overdose is. Like what is happening if you take too much fentanyl or if you take too much of another drug, right? What's happening in your body? What's happening is oxygen starvation. So an opioid overdose is those same receptors that or the drug that they sit on can get overwhelmed and they can suppress breathing. Okay. So when you have too much of the drug in your system, it slows down our breathing or even stops our breathing. And the reason we talk about that and we understand why that's how an overdose works is it helps us understand why we talk about Narcan. I'm sure I saw some nods with like the One Pill Can Kill campaign and the Arrive Alive. I'm sure you might have heard of Narcan before. We talk about it because it reverses overdose. Now, that's really specifically opioid overdose, right? So it's going to work on things like fentanyl and heroin and like painkillers. It won't work on things like meth or cocaine unless they have fentanyl in them. So we talk about this because they can save lives, right? So what is it though? What is Narcan? So first thing to know, Narcan is the brand name. Naloxone is the generic name. They're the same thing. So you'll hear both. You'll see boxes that say both. They're the same thing. They work the same. It's an opioid antagonist, which is a fancy term to mean all it does is stop the opioid from working. So what it does is it goes in your brain, it finds those receptors the opioids are sitting on, and it kicks them off. And it takes its place so the opioid can't have an effect anymore. So all it does is help people breathe again. And that's really important, right? It saves people's lives every day. It's really effective. So 83 to 100% of opioid overdoses can be reversed with Narcan, right? It's really safe because of how specifically it works. You can give this to anybody. So kids, dogs, people who are pregnant, people who are immunocompromised. It's a really safe thing to give people if you think that they're overdosing. Now, one thing I want to kind of point out though is that it only works for like 30 to 90 minutes. So if you give somebody Narcan and you don't get them an ambulance or you don't call 911, then the overdose can come back. And so we want you guys to know that it's not enough to just give somebody Narcan. You need to call 911 and get help. Another thing to note is that it's shelf stable and long lasting. So if you get a package, and you can get them from us at the Coalition, if you get a package of Narcan and you're looking at it, you might see like an expiration date, you might see like a temperature range, but they last way longer and in way worse conditions than it says on the package. So note that if you see some and it's expired, it actually lasts 10 years past the expiration date. And it can last 3 years in a hot car before it loses effectiveness. So it lasts a really long time. And so if you guys have Narcan, use it, keep it on hand. It lasts way longer than it says on the package. You guys can get it lots of places. It's over the counter, it's safe, it's legal. You can get it at Target, Walgreens, CVS, and pay for it over the counter. But you can also get it for free from places like us, hospitals, syringe exchanges, all those kinds of places. Narcan works really well, and it saves people's lives every day. Something I didn't put in the slides, but I kind of like to emphasize when we talk about like, why do we talk about Narcan so much? Besides the fact that people are overdosing, why is it important that all of us carry it, or all of us have it, or all of us know what it is? So as I said, an opioid overdose is oxygen starvation, right? So we know that going without oxygen is bad. So brain damage occurs from lack of oxygen within like 4 to 6 minutes. The average ambulance response time is about 5 to 8. And so what that means is if you have Narcan, you can save somebody's life, and it's going to work way better, and it's going to help them stay alive much better than if we would just wait for an ambulance. And so we're going to save people's lives every day if all of us have it. Anyone have questions so far on kind of the background of what opioids are or what Narcan is? I'm going kind of fast because I know we have a couple topics to cover today. Any questions? So then what does it look like if someone is having an overdose, right? What do you guys need to look out for, to recognize, to know when somebody needs help? So again, remember that an overdose is lack of oxygen. So we're looking for signs of oxygen deprivation. So you might hear somebody who's struggling to breathe. So there might be like snoring sounds, there might be gurgling, there might be gasping. Sometimes people aren't making any sound at all. They might be throwing up or vomiting. Their pupils could be really, really small. You might see their skin or their lips or their fingernails look kind of blue or gray, again, because the lack of oxygen. Their skin could be cold and clammy. They're gonna have a heavy nod. They won't respond to pain or their name, and they might look passed out or unconscious. Their pulse could be like low or slow or kind of erratic, or there could be no pulse at all. So again, we're looking for signs that somebody is kind of not waking up, or that they're struggling to breathe, or that they're not breathing at all. And that's kind of like the big picture of what you're looking for to know when somebody needs help and when it's time to give Narcan. So then what do? I'm gonna show this little video. It's like a minute. There's no sound. It's just gonna show you what Narcan looks like in action. And then we'll kind of go through it step by step. So as you can see, Narcan is intended to be super, super simple and easy to use. It can be shown in that 1 minute video, right? But we can talk about it a little bit more in depth to get like a better understanding of walking through what happens if you recognize the signs. So you come across somebody, you're with friends, whatever the case may be, and you recognize signs of an overdose, right? They're gasping, or they're not breathing at all, or they're not waking up, or they're kind of blue. What do? First, try to wake them up. Make sure they're not just asleep. Make sure that they're actually like not able to wake up. That's a key sign of an overdose, right? That they're unresponsive. So how do you wake somebody up? You can shake their shoulders, you can shout their name, right? But you can also do some other stuff. So you can do what we call a sternum rub. You take your knuckles, you rub it up and down on their like chest. And that kind of is a little uncomfortable. So that'll wake most people up. You can also like tug on their ear, or you can like pinch the underside of their arm, like where it really kind of hurts. So if somebody's not waking up to that, that means they're unresponsive. And we want to go ahead and give Narcan. So Narcan is just a nasal spray. You're going to see boxes. I don't have one on me, but most have about 2 doses. And they're just these little nasal sprays, kind of like Flonase. So all you're going to do is you're going to put 2 fingers on either side of the nozzle. You're going to put 1 thumb on the plunger. You're going to insert it gently into their nose, just about until the tips of your fingers kind of hit the edge of their nose. And then you're going to press all the way up in the plunger. And that's it, right? That's all it takes to give Narcan. It's just a nasal spray. So you recognize the signs of overdose. You've tried to wake them up. They're not waking up. You give them the Narcan. What do you do next? You're going to do a couple things. First, you're going to call 911. Again, it's really important they get medical care. Again, they've gone without oxygen for a little bit, maybe, and also because the overdose can come back. And so we want to make sure they get checked out by an EMT or they go to the hospital. They call 911. And then if you're certified, or you know how, and even 911 can walk you through it, you can do CPR or rescue breathing. And you can also put somebody in the recovery position if you're not comfortable doing those things. So the recovery position is where you put somebody on their side, their hand under their head, their knee over the other knee, and that helps keep their airway clear, and it stops them from choking if they were to throw up, which sometimes folks do when they come out of an overdose. So that's it, right? And then what do you do next? You see if it worked, right? Let's try to wake them up again. So you're gonna do the same thing. You're gonna do the sternum rub. You're gonna shout their name. You're gonna shake their shoulders. You're gonna tug on their ear. You're gonna pinch their arm. If they're not waking up, you're gonna give another dose after about 2 minutes. Essentially, you want to give a dose of Narcan about every 2 minutes, and then do that rescue breathing or recovery position in between. And you're gonna try to wake them up. If they're not waking up, you're gonna give them another dose, and you're gonna repeat that until either they wake up and something changes, or until EMTs or ambulance get there. And that's all it takes to give Narcan. It's really simple. Does anyone have any questions about recognizing an overdose or using Narcan? Okay. Go over some basic stuff just to keep in mind. One thing I really want to make sure you guys know is something called the Good Samaritan Law. So if you're at a party and you guys have been drinking, or you go somewhere and someone's taking drugs, right? We want you to know that there's a law that protects you from getting charged with any crimes, because we want you to call 911. We don't want anyone to avoid calling 911 and avoid getting someone in an ambulance because they're afraid of getting in trouble. So know that that's your right to avoid criminal charges. It's called the Good Samaritan Law. So don't be afraid to call 911, and make sure you know that that's a protection for you. Sometimes folks will ask us, like, what about I have Narcan on me? Like, I recognize the signs of an overdose, but I don't have it. What do I do? One, call 911, right? That's something you can do. You can do rescue breathing. You can do CPR. Just try to keep them awake, try to wake them up. You can also help get them moving. So if they're still kind of awake, you can get them up, you can get them moving. You can even help like move their limbs around. The more that somebody moves, the more the opioids circulate in their body. And then that means the less that they're focused in the brain to affect breathing. So if you recognize an overdose and you don't have Narcan, it's just about staying calm, calling 911, doing rescue breathing or CPR, and even doing something like helping them move or putting them in the recovery position. Okay, I'm gonna go with some true or falses. I'm kind of just going through them. I would love it if somebody answered them, but that's okay. I know I hate to be on camera on Zoom too, so. Okay, does anyone know this one? Anyone want to volunteer? Can you overdose from just touching or being near fentanyl? I'll take a thumbs up or a thumbs down from somebody on camera. And seeing some head shakes. So yeah, thumbs down. So you cannot overdose from just touching or being near fentanyl. Thank you. That's something that a lot of people think. That's something they hear. But fentanyl cannot be absorbed through the skin that way, just from touching it. And so we want you to know that, because we don't want you to be afraid to give somebody help, to give them Narcan or CPR, because they've had fentanyl, right? True or false? Naloxone can last 10 years past its expiration date. Yes, thank you. That's true. We talked about that today. So it lasts a lot longer than people think it is. True or false? So sometimes something like a diabetic emergency can look really similar to an overdose, right? People get pale, they get kind of nauseous, they like might get kind of clammy. So if you see somebody having a diabetic emergency, but you thought it was an overdose and you gave them Narcan, is that going to hurt them, help them, hurt them? Yes, correct. Thank you. So it can't hurt them, right? It won't help, but it won't do anything at all. Narcan is pretty neutral unless it's an opioid overdose. And so if you see something that you think is an overdose and there's no way to know, go ahead and give the Narcan. You're not going to get in trouble and it won't hurt them. What about if somebody has other drugs? Like they are having an overdose, but it wasn't an opioid. Will that hurt them if you give them Narcan? Correct. It will not. Again, it won't help them, but it won't hurt them either. And in fact, those drugs could have had fentanyl in them even without them knowing. So it definitely doesn't hurt to give the Narcan just in case. What about if you see somebody overdosing, you've given them the Narcan, does that mean that there's no harmful effects or no other things to worry about? Right, right. One, we know the overdose can come back even after Narcan. And two, it's still oxygen deprivation, right? They've gone without oxygen for who knows how long until you caught the overdose. And so overdoses are still dangerous. They still have harmful effects. So whatever you can do to stay safe and avoid overdose at all, of course, is the best option. Okay, where can you get Narcan? Like I said, you can buy it, but you can also get it for free from us. You can pick up just 1 or 2 doses. You can get a whole box. If you guys would like some, let us know, let Sam know, email me, and you can come pick it up. If you guys are interested in like learning more about this work, learning more about overdoses in Sacramento, what kind of work is being done in this kind of field, we have these coalition meetings. The next one is in July. You're welcome to join our coalition. We also have a meth coalition to talk about like recovery and prevention and treatment for methamphetamine use. So those are some great learning opportunities for y'all if you're interested in this kind of stuff. Okay, anyone have questions about all of that? The Narcan, fentanyl, anything like that? No questions? Anything in the chat, Sam? Nothing. Okay.
No, just some answers to your questions.
Oh, awesome. Thank y'all. Appreciate it. Perfect. Okay. So I'm going to roll right in. We have 8 minutes left. I'm going to roll right in to talking about kind of careers in harm reduction to give you guys some more ideas of stuff you can do, kind of related to the medical field, but not so much like being a doctor or like a rad tech. So first, what is public health? What is community health? What are harm reduction, right? What am I talking about? So these are fields that are still focused on health, right? On helping people stay safe and healthy and save lives. But we're focused a little bit more on things like education, outreach, and providing direct services to people, sometimes outside of healthcare settings, right? This is doing stuff that's one-on-one. It's doing like public health campaigns. It's doing education. It's providing people Narcan. It can look a ton of different ways, which I'll show you what some of those jobs can look like. But really, you're talking about taking care of your community. Community health is very local focused typically. Public health can be really big, right? You can look at like US level or national level, but you can get all the way right down to community health, which is talking about the people right around you. And then what is harm reduction, right? So that's kind of more of a subset of both of those things. And that's what kind of Narcan is. So you might have heard the phrase harm reduction. Harm reduction is just providing services without judgment, right? No matter what people are doing, we want them to be as safe as possible. So there's a lot, it's typically used for things like Narcan or syringe exchanges. It kind of came out of the idea of helping people who do use drugs to stay as safe as possible. But there's lots of things that we consider harm reduction. Seatbelts are harm reduction, right? We can't stop all car crashes, but can we help prevent people from getting hurt as much as possible? Yeah. Life jackets, right? We can't stop all people from going into water if they're not able to swim very well or if it's dangerous, but we can help try to prevent drowning. That's harm reduction too. And so public health and harm reduction, all these things are just keeping people as safe and healthy as we can and giving them the tools so that they can do that for themselves and for the people around them. So I'm going to give you some jobs that I've had in this field to give you kind of a sense of like what that could look like when we talk about things like public health or community health or like non-medical jobs that are still really related to health and safety and well-being. So one of the jobs I had was as a case manager. A case manager is a really broad term. There's so many different types, but essentially it's working with people one-on-one to help them navigate healthcare and to navigate social services. So taking people to doctor's appointments, going with them into the appointments, taking notes, helping them understand what their conditions are, helping them organize their medication, taking them to the DMV office to get their ID because you need an ID to get housing. You can't be healthy for, there's all these different things that affect health, right? Besides just what the care you get in a doctor's office. And so being a case manager is kind of being on people's side and walking them through all those things. I was also a community health worker, and that can look a lot of different ways. But the idea is to be out in the community, working with people where they're at, right? So these are all just pictures of things I did. Went to festivals, got great food, drove people around in the van, gave people rides. I went to like homeless encampments, met a lot of dogs. I went to Pride. And so it's giving people education, it's giving them resources, it's giving them stuff like Narcan, making flyers, doing kind of social media campaigns. Again, it's about looking at what affects health outside of a doctor's office and how can we help them there. And so that was one of the things I did that I really, really enjoyed. The next thing I did was kind of moving away from those things a little bit, focusing a little bit more on like sexual health, HIV, harm reduction. And again, the thing that I love most about all these jobs and that I love most about like community and public health is that you're not just in an office all day, right? Doctors' offices I don't think are boring, but sometimes corporate offices are. But this way you get out of the office, you get to go to lots of different places. I did HIV testing where I provided people tests. I did care navigation where I helped them kind of with paperwork. I did harm reduction where I gave people Narcan. I set up condom dispensers. I met lots of people who do other kind of work. And so again, these are all jobs that can look so many different ways, but again, is meeting people where they are, providing them resources, providing them health education, and working with people in the community. What I do now is a little bit different, a little bit the same. So I do presentations like this. I go to people's jobs. I go to churches. I go to schools. I work on like social media campaigns and providing health education. And so again, the same thing, right? Letting people know what the resources are, letting people know what health education is, and kind of helping meet people where they are to provide them the tools they need to keep each other safe. Those are things I've done, but there are 1,000 things in community and public health that I really encourage you guys to look into, right? These can look so many different ways. There's so many different options to help people, right? So if you still want to be like a provider, like a doctor, you can think about focusing on something like medication-assisted treatment, right? Like helping people recover from substance use. You can think about being a peer-led counselor, where you get like a certification, but you're not a doctor, but you're helping people through the process of like recovery from addiction. You could be a licensed social worker, and that could be more clinical with like therapy, or it could be more social, like providing resources. You be a nurse practitioner that does psychiatric care. But you can also do non-medical things too, right? You can write grants. All the work we do requires money, requires funding. You can be the person that helps get people that funding. You can be a housing navigator to get people off the streets. You can be a peer counselor if you've had experience with mental health struggles or with substance use. You can meet people on a one-on-one level. You can do outreach. You can do syringe exchanges. You can do, like I was a community health worker, a health educator. There's a lot of different things you can do in this field that aren't just being a doctor. Okay, that's it for me. Does anyone have any questions about any of that? A lot of different topics in there.
We have one question in the chat. What does education look like when going into harm reduction?
Like education for us to be qualified to do it? Yeah, so that's the other great thing about community and public health is it's a lot more open, right? Less education required. So I have a bachelor's, and I'm currently in a master's program. And a master's can help you, like a master's in public health, can kind of help you move up and help you do different things. But a lot of times you just need a bachelor's. Sometimes there's like certification programs you can do. And I've worked with a lot of people who don't have a bachelor's, who don't have a degree past high school, because the experience people have in their lives can make you just as effective at doing this kind of work more than like school can. So it can look a lot of different ways. It really is what you make of it, and using the tools you have and the experiences you have to figure out like what the right path is.
All right, we're at time. So thank you, Joanna. And if anybody has any further questions, you can email me or email Joanna, and we will help you out. So thank you.
Thank you all. Nice to meet everyone.
All right.
Bye.
Up next is Dr. Leo Chen. He is a neurologist with Kaiser Permanente. So welcome, Dr. Chen.
Hey, everybody. How are you? This is, I was told this is going to be interactive, so I'm expecting questions. Otherwise, I have nothing to show you all. But I'm excited to be here, and I am a neurologist. Specifically, I take care of people with seizures. How many of you know what seizures are? Yeah, it's a pretty common condition where the brain can behave abnormally, and people can have a variety of different symptoms based on where the seizures come from. And so it's a very interesting condition that I take care of on a day-to-day basis. Again, like Sam said, I work at the Kaiser Permanente in Sacramento. I also do a variety of other things. So I do quality review for other physicians. I participate in committees where we do a lot of events for the wellness of the physicians, making sure that my colleagues are taken care of, and so are their families. I teach at the UC Davis Medical Center, so where I work with residents, and also teach at the California North State Medical School, where I'm a mentor to have medical students shadow us and learn what neurology is about. Um, I So with that, I want to open it up to questions. I want this to be interactive, and you know, I I welcome all questions.
All right. I'm going to get started with one. So what made you pick this career?
So my dad, my parents are actually physicians, and so when I grew up, that's the profession that I knew, and I kind of just stuck with it. Honestly, I think it is something that I'm so used to. I didn't think twice about it. Um, Obviously, there were a lot of hoops that you have to jump through to be able to become a doctor, but I was able to obviously accomplish all of that and become a doctor. So I think that's a relatively straightforward path for me personally. In terms of being a neurologist, I think that when I started medical school, I thought about the heart and I thought about the brain because I thought these two organs are the most exciting ones. Um, and I just kind of settled on neurology. I did my rotation in neurology, shadow neurologist, and I just find it fascinating. So pretty straightforward. And so I think it was a relatively easy choice for me.
All right, moving on to the next question. We got several in the chat. So what education do you need to be a neurologist?
So you start from going to college, and during which time you'll be thinking about applying to medical school. And you can obviously look up resources to find out how to do that. Obviously, it's similar to what you have to do when you apply for colleges. You look at the list of institutions you want to get into, making sure you satisfy the prerequisites, and do well, obviously, in school, do well in your testing, and also demonstrate your interests, right? Because medical schools are very competitive. So we're always interested in finding people who are passionate, exciting, knowledgeable, kind, compassionate. Think of it this way: if you were someone who is selecting people to be future doctors, who would you want to be that person, right? So uh, it's one thing to say that you want to do something, but it's another to demonstrate. And so I think the key there is that you have to show a track record of doing something that makes you a good future doctor. After you go to medical school, which typically is 4 years, then you apply for residencies, and that process is again another round of applications, going around the country to interview for in my case a neurology spot. So different institutions have different openings for different specialties. Neurology is one of them. So you decide during medical school which specialty you want to go into, and then through a process of application again, you would be submitting your application. You'll be interviewing at different institutions, meeting different people. You will then rank the institution that you would like to go to, and it's a match process. So you rank them, and they rank you, and then if the two sides match up, then you get matched up to be in the residency. So I did my residency at UCLA, where I had some family tie, and also I know it's an excellent neurology program. And after being a resident there, which is 3+1, and so when I say +1, it means that the first year after you graduate from medical school is what we call an internship. So an internship is like think of it like a general medical education as a physician, as a doctor. So you graduate from medical school, now you have an MD degree, you do a year of internship in medicine, in my example, because neurology is a medicine discipline. And then after that, you do 3 years of dedicated neurology training. And I personally got interested, as I said, in epilepsy and seizures. So then I applied to do what we call a fellowship. So a fellowship can range from a year to 2 years to 3 years, depending on if it's clinical, if it's research. So I did 2 years of fellowship in epilepsy. And when I finished that program, then I become a subspecialist in neurology, specifically in epilepsy, and that's what I practice now.
Okay, what does your everyday schedule look like?
I am a mostly outpatient person. So we have inpatient, we have outpatient. Inpatient is taking care of people in the hospital. Outpatient is taking care of people in the clinic. And so my typical day is 8 to 5. And essentially the schedule is filled with people who have, neurology questions. And these patients are people who were referred to me by their primary care doctor, by other physicians. It's pretty straightforward. You see new patients who are coming to you with new problems. Usually you have a little bit more time with them because you're just getting to know them. And then you have you see your follow-ups. So follow-up meaning that the patient you've seen before, and now you're just following up with them to see how they're doing with their new medications, to see how they're doing with their seizures. In my example, for example, so it's pretty typical work hour for me. Obviously, different disciplines have different schedules. Sometimes I can be on call. And when I'm on call, it means that, for example, when the emergency room doctor has a question, they may call me to help answer that question. Let's say the emergency room doctor called me and say, hey, this person is coming into the emergency room because he or she is dizzy. And these are the symptoms, and this is what's been going on. These are the studies we've gotten. What are your recommendations? And so I would give recommendations to the emergency room doctor. Typically for me, in my particular role, I don't need to go in the hospital, so I answer questions mostly on the phone.
Okay, how was the schooling to become a neurologist, and what was the toughest point of your education?
I think that throughout the education, there were, I think different life stages give you different challenges. Right now, you're all high school students, you can focus on your school, etc. When I was a medical student, I was able to focus on my studying as well. I didn't have a lot of sort of responsibilities per se. Some of you might be in a different boat. I do have classmates in medical school who also has to, figure out the finances. A lot of them, including myself, would take on student loan and things like that. Um, I think medical school is so busy. I think that some people obviously would have side jobs, try to earn some money on the side by tutoring other students and things like that. So that can be obviously additional responsibilities. And then when you start sort of residency, that is a challenging period in which you're working as a resident, meaning that you have an MD, you're a doctor, you're supposed to be in the hospital taking care of patients, answer really tough questions, but you don't really have all the knowledge just yet because you're learning at the same time. So you are a student, but you're also a frontline worker, right? So the pay is sort of not not uh, it's 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 sort of like think of it as a work study kind of program, right? So the pay is not fully up to where a full-time neurologist or physician would make. So it's so financially it could be challenging during that time as well. A lot of us would start to have families, for example. You may get married. You may even have kids during residency. So you start to accumulate and add a lot of different responsibilities during that time. So that can be pretty tough. And work hours are long. You're oftentimes on call in the hospital, which means that you sleep in the hospital. You may be running around the hospital all night long. And there's being some regulations in how many hours people can now work in the hospital, because residency programs used to be even more, the word that people use is malignant, right? So what that means is that um, because of that high expectations of you working and learning all in that short period of time, that a lot of people end up working 100, 120 hours per week, which was very difficult on the mind, on the body. And also people find that when people work so many hours, they are prone to making mistakes. And so because of all of that, there has been new regulations to limit how many hours people can work during residency. So I would say that is tough period. The other tough point would be once you start working, you no longer have a mentor, an attending, we call them. So these are your teachers to ask questions of. So you're now on your own. You're expected to know the answers. So that's when you start to realize that no one is looking over your shoulder and you are taking responsibility for another person's health, another person's life. And so that can be very humbling and very tough as well. Sometimes we do make mistakes, and people are going to be very hard on yourselves. Um, Oftentimes, there is a culture where we don't talk about our mistakes because we have the fear that we're such high achievers that we hate to project the impression that we're not good enough. And so there are a lot of psychological issues that can come with that. Obviously, I think we are moving in the right direction in terms of being open about those types of issues. But I would say that is that is a tough part of your career as well when you start working.
Next question. How do you handle uncertainty when you're not fully sure of a diagnosis or the treatment path?
You look it up, right? So you want to be honest with your limitations, and you look it up, and then you ask colleagues, you ask other people who are more experienced than you, and you're learning all the time. So that part never stops.
How is flexibility in the profession? Do you work on set days, shifts?
Flexibility depends on your specialty. So for example, let's say if you were an emergency room physician, which is shift-based, then you have some flexibility in maybe picking your shifts, etc. But just be aware that whichever institutions you go to, whatever job you take, it really depends on the institution, on the job you take, on the flexibility, right? If you are in a place where you're just the starting person, you may not get the choices that you want. For me, flexibility is relatively good because I joined a relatively large group, which means that there are colleagues who can cover for me when I'm not around. But obviously, there are different practices. Say if you're a solo practice, meaning that you're responsible for your own clinic, then obviously you don't have potentially the flexibility to walk away and not take care of your patients. But obviously, arrangements can be made on that, etc. Some people feel like in your own practice, you may have more autonomy, which just means that you have the ability to decide when you want to work. But the caveat, of course, is that when you're running your own clinic, it's kind of like running your own business. So if you ever work with a boss of some type, you know that there is added pressure for you to be at work all the time, for example. So I think that, you know, there are pros and cons of working for somebody versus working for yourself. And a lot of sort of bureaucracies come with running your own practice, for example. Um, Specifically for me, again, because we have a larger neurologist group, I have been able to take time off when I needed. I have someone who covers for me. So I would say personally, my flexibility has been pretty good.
Can you break down what a neurologist does?
Sure. So neurologists take care of problems with the brain or the central nervous system, as well as the peripheral nerve and the muscles it innervates. So we have people who are in neuromuscular specialties. We have people in strokes, for example. We have people in dementia, for example. So some of the common conditions you might have heard of would be Parkinson disease, right? Michael J. Fox, which is the actor for Back to the Future, has Parkinson disease. You may have heard of, you know, seizures I mentioned earlier. Some of the prominent people may have seizures that you might be aware of. Multiple sclerosis, some people talk about. There's about a lot of awareness of surrounding that. Stroke, obviously, very common, right? So you might even on the street, if you're observant, you will see people who may be paralyzed on one side of their body, or even unfortunately, you may know people in the family who's had strokes where maybe they cannot see or talk anymore, or maybe they're paralyzed, you know, they can't speak anymore. So stroke is a very common condition we deal with. And again, dementia. So dementia, a common condition is Alzheimer's disease. So Alzheimer's disease, as we age and as our lifespan has become longer, there are more and more people who's diagnosed with dementia later in life because we are predisposed to having perhaps memory issues. So these are people who would come in who have memory loss and who need a lot of support and education. So those are some of the conditions that we deal with. The other common one with headaches, migraines, some of you may even suffer from that. And just know, you know, there are medications out there that we use specifically for headaches and migraines. So if over-the-counter pain medications are not working, that's when you might talk to a neurologist to see what other therapies are out there to help you out.
Next question, how do you work with neurosurgeons? What are the difference between the two?
So that's a great question because there can be confusion between the two. As I say, neurologists work mostly for me in the outpatient setting where I'm interacting in clinic. I'm sitting across from a person or sitting on the screen with someone to talk, to educate, to learn, to diagnose, to discuss medications, etc. Whereas a surgeon, they are working in the operating room. And the operating room is where you use different methods to open people up to try to treat their conditions by using scalpel, by using techniques to work on the body when the person is under anesthesia, when they can't, you know, when they're out of it and can't feel anything. And so, for example, a neurosurgeon might operate on brain tumors, right? So a neurologist like myself may be talking to a patient and say, the patient may say, hey, you know, doc, I'm having trouble seeing out of the right side of my vision. I say, oh, that sounds concerning. I do an examination to see what the problem is. And I realize that the patient has a visual field defect, meaning that cannot see one side of their vision. Then I say, well, this is very concerning. We should do a scan of your brain. So I would do a scan such as a CT or MRI. MRI is a technique that we can see the soft tissue of the brain, order the scan. The results come back from the radiologist saying, oh, unfortunately, this person has a brain tumor on the left side of their brain, which controls the right visual field. So having that information, then I can refer the patient to a neurosurgeon to say, hey, Dr. So-and-so, this is a patient I'm taking care of. he or she cannot see the right side of the visual field. On the scan, there's a left-sided brain tumor near the visual cortex. The neurosurgeon, when they take that information, they may do additional scans, they may do additional procedures to try to map out the area that's involved. And then they would plan the surgery to actually go into the operating room, open up the skull, and resect or take out the tumor. They would send the tumor to pathologists to take a look to see, how what's the grade of the tumor, for example. And then after the operation, then they may decide on what to do for the follow-up part, whether they need to see a oncologist to do maybe they need to see a radiology oncologist to do like radiation therapies in addition to chemotherapy, for example. So we divide our labor up in different ways.
Next question, what potential do you think AI will help with your job in the future?
I'm already using AI. So when I talk to patients now, we used to have obviously write down our own notes. In the old days, it's paper and pen. Nowadays, we do it mostly on the computer. With the AI, addition of AI technology, we're now able to just get the patient history. The AI is able to listen to the conversation and summarize into a note. So it's like think of it like an electronic scribe. So a scribe is usually a person or a service that writes down everything during a physician encounter with a patient. But AI technology has allowed us to use the technology to be able to scribe the medical notes for us. So it's been very helpful.
Great. Next question. Have you ever doubted your path into medicine or neurology, and how did you push through that doubt?
It's a good question, very insightful. I think that because to become a doctor, it takes such a long road. I think that everybody I've talked to would have doubts from time to time. And so I think that this is not a professional for everybody. There are certainly people who initially want to go into medicine and they may quit at various stages, realizing that their time is better spent doing something else. And so I think just like anything that you do in life, even right now, let's say if you, is into sports, or maybe you're into music, or maybe you have a hobby that you really like, you realize that different times of your life, you may fall in and out of love with something that you want to do. And I think that during those times, it's where, your personal life becomes relevant in terms of, what support do you have around you? Who can you talk to? Who are your friends? Who are your family? And how does your brain work, right? Everybody solves problems in different ways. Some people may go down a very logical path to list the pros and cons of staying in the profession. Some people may be more emotional. They may go see a therapist or counselor, and that's very common as well. And so I think that everybody I know in medicine, go through periods where they may not be happy. They may want to quit. So it's something that we all have to deal from time to time. But just remember that it's a long-term career, and so there is going to be ups and downs. And I think that it's probably true in all different aspects of life, and it's true in all professions, I would imagine.
What is the most important piece of advice you give your patients for maintaining long-term brain health?
So I tell them that living a healthy lifestyle is the most important thing. In fact, there is no medication that's being shown to be better than eating healthy and exercise, sleep well, having good social interactions to be, no medication can do that better than doing those things. There are these people who live in what we call blue zones. So blue zones are areas of our world where people live a long, healthy life, and that includes their brain health, includes their body, physical health. And so I would encourage you, if you're interested in that question, to look up blue zones and look at like how people live in those areas and how do they maintain their health.
What was your favorite subject and how did it affect your career choice? If so, why?
Favorite subject? I I didn't necessarily have like a favorite. I think generally speaking, I'm thinking back like in high school, biology, I like physics, and I think partly that's bias, right? When you do well in certain subjects, you like it better. So I was obviously doing well in those subjects. In college, I liked anatomy. Again, I liked biology. And so those are the things that I was really like, interested in.
Okay. I think that's all the questions that we have. So thank you so much for joining us. Well, I guess I
Yeah,
can
of
join.
course. Thank you for having me.
We appreciate your time and have a wonderful rest of your morning and afternoon. Thank you.
Great to see you all. Thank you. Bye-bye.
All right. We're going to take a 2-minute break, so be back here at 11:31. All right, guys. I don't see Dr. Trong on here. And we know that they're super busy. So I will get a hold of him and see if we can reschedule, but we'll go ahead and end for the evening. Let me see. Let me get the winner of the gift card. The winner is Solomia. All right, I'll send you a $5 gift card. All right, we're done for the day, and I will see you back here on Friday at 10. Thank you.